Inflammatory Effects on Radiographic Interpretation is presented by Dr. Ross Barlow, Assistant Professor, Department of Oral Maxillary Facial Radiology, Faculty of Dentistry, University of Toronto.
I'm Dr. Ross Barlow, Assistant Professor, Department of Oral Maxillofacial Radiology at the University of Toronto, Faculty of Dentistry, and I'm the co-head of the undergraduate program in radiology. I'd like to speak to you about the inflammatory effects on radiographic interpretation and give some examples and some differential diagnosis around the inflammatory response of bone and to some degree soft tissue on what is interpreted on the radiograph. Injury is an alteration to the environment that causes tissue, including bone, damage. An injury triggers three related responses: homeostasis or clotting, the inflammatory response, and the immune response. I would like to look at specifically the inflammatory response and the changes that occur in bone and subsequently can be seen in the interpretation of radiographs. Inflammation per se is a non-specific response to injury and occurs in the same manner regardless of where the injury is, whether it's in bone, soft tissue, or what part of the anatomy is affected. Pulpal injury, being the injury to the pulpal tissue of the tooth, which consists of blood vessels, lymphatics, and neural tissue, can be of a number of origins. It can be mechanical, from the machining of the tooth, possibly thermal changes from that. It can be thermal from external thermal forces, for example, hot fluids or the application of heat to a tooth, which causes an increased blood flow and thus causes inflammatory response to the pulp. It can be chemical from things that may be applied to the pulp, cements and various other protective medicaments that we use, or it can be bacterial in the case of a carious lesion extending to the pulp tissue, and through that, from the carious lesion and the environment, the neural cavity, bacteria extends to the pulp, generating an inflammatory response. The initial response of pulpal tissue to injury is similar to other tissues. The discussion of the inflammatory response per se from a histological microscopic point of view could be discussed at another time. The problem being that the inflammatory response in pulpal tissue, the consequences and final result are somewhat different. The main reason for this is that pulp tissue is confined by a very, very small apical foramen where the blood flow, lymphatic flow, and the neural tissue enters the pulp and indeed exits the pulp. Normal tissue does not usually have this same confinement, and the problem being that with pulpal tissue, when the inflammatory response occurs, we can end up with strangulation of the pulpal tissue and pulp death. Pulpitis, itis always meaning inflammation, so inflammation of the pulp, is caused by the confinement of the vascular blood flow and the subsequent strangulation of the pulp, accompanied by the pulpitis, which is one of the first causative or pain experiences that the patient will feel. Brief review of periosteum. Periosteum, in terms of dental nomenclature, is the bone that makes up the socket of the tooth. This periosteal bone is referred to as lamina dura. It is, however, not much different than the periosteal bone that one would see enveloping other bones other than the articular surfaces, which are enveloped or covered in cartilage. The periosteum throughout the anatomy, including the lamina dura of the tooth socket, consists of two layers: an outer dense connective tissue layer and an inner loose osteoblastic layer which produces bone. Sharpie's fibers, which are fibers that generally throughout the anatomy attach this periosteum to the outer lamella of the bone. In dentistry, the Sharpie's fibers extend from the periodontal ligament to the lamina dura, or the periosteum of the socket, and that is the one attachment of the periodontal ligament, the other attachment being the Sharpie's fiber extending into the cribriform area of the cementum of the tooth. This forms the ligament which holds the tooth in the socket and indeed gives it some flexibility. The inflammatory response generates physiological changes, and these changes can be seen radiographically. A certain amount of demineralization has to occur before the changes can be seen on a radiograph. There is some discussion and controversy as to exactly how much demineralization has to occur. Numbers can vary anywhere from 12% to over 50%. Needless to say, the initial inflammatory response may not generate any interpretive changes in the radiograph until a certain amount of demineralization has occurred. The first rendition, artistic rendition of the tooth could be taken as a generic tooth, and we can see that we do have the tooth, the enamel, the cementum. One can see the periodontal ligament from the cementum to the lamina dura, represented by the blue line. This would be a normal, healthy tooth. We can see in the next diagram that an insult has occurred close to or at the pulp horn of this particular tooth. This insult could be a carious lesion, could be a fracture, or could be a dental restoration which is encroaching close to or even into the pulpal tissue. The result of this insult can cause what is referred to as a hyperemic pulp, or an increased blood flow to the pulp, referred to as hyperemic pulpitis. This pulpitis at times can be reversible. The insult does not offend the pulpal tissue to any great degree. The patient will experience sensitivity to hot and cold for a period of time. A layer of reparative dentin is often set up around the pulp and serves as a protective barrier. This is referred to as reversible pulpitis. In many instances, however, the pulpitis, the offense to the pulp tissue, is irreversible, and we begin the sequence of pulp death. One of the consequences of the physiological changes from the inflammatory response within the pulp, although not necessarily the first one, these consequences can follow in different sequences, is referred to as a thickening of the lamina dura, or the periosteum of the socket. One must be aware that there are variations in the thickness of lamina dura from patient to patient and from tooth to tooth. Some teeth, for example, the lower molar teeth, tend to have fairly thick lamina dura because of the thickness of the root. So one has to be cognizant of these anatomical variations and react accordingly when examining a radiograph for interpretation. So thickening of the lamina dura would be a first response. Oftentimes when one sees a thick lamina dura, one looks for a causative factor. These causative factors, generally speaking, although there may be others, but the two major causative factors are that we have a carious insult to the pulp, a restoration, or on the other hand, we have a restoration impinging close to or into the pulpal tissue, which may be generating the inflammatory response and the subsequent thickening of the lamina dura. Trauma is another cause. Tooth death through trauma may generate a thickening of the lamina dura through the inflammatory response. But again, one must always be aware of the fact that you may have a deep filling and you can have a normal thickened lamina dura, which is part of the normal anatomy of that particular tooth or that particular individual. Here we see an example of a thickened lamina dura on a molar tooth. We see a restoration that is quite deep, impinging very close to, if not at the pulp horn of the tooth. And the other response that can sometimes occur hand in hand with the thickened lamina dura, or may occur on its own, is that we have an increase in the periodontal ligament or periodontal membrane space. These two sequences, following either individually or together, are usually or often the first indication that there is pulpal insult an inflammatory response, and this is generally an irreversible response to the insult ending in tooth death. The next sequence that occurs is that if the insult continues, or the insult may be acute enough that one does not see, or the radiograph may not have been taken at the time that the lamina dura thickening is observed, is that the lamina dura discontinues. It is broken down, we can no longer follow the lamina dura, and again, the same criteria should be held in place. Number one, is there a causative factor, either insult from caries or a deep restoration, although oftentimes, again, trauma can play a part in it. You can see individuals where the lamina dura appears on teeth as being very thin. It is a good idea when assessing and interpreting these areas that one looks at the lamina dura of adjacent and accompanying teeth to see exactly what the general appearance of the individual's lamina dura is. Here we see a radiograph compared to the diagram, and it very clearly shows that we have a discontinuation of the lamina dura, and the next sequencing that occurs is that the bone, because of the inflammatory response and the exudate and toxins that are being forced through the apical foramen of the tooth, are demineralizing the bone. After a certain extent, after a certain amount of demineralization occurs, one finds that the bone begins to rarefy or thin out, and this is observable on a radiograph. I should point out again that this is not observable on first insult because you do require a certain amount of demineralization to occur before one finds that it is observable on a radiograph. But we can clearly see in the diagram and the adjacent radiograph that besides discontinuation of the lamina dura, we also have a rarefaction or rarefying of the bone, referred to as rarefying osteitis. The next sequencing that can occur, and again, not necessarily in sequential order, but the next sequencing that can occur is besides the rarefying osteitis, the bone tends to increase its mineralization, setting up a defensive mechanism to prevent further spread of the toxins through the bone. This may occur with rarefying osteitis and is referred to as sclerosing osteitis. Depending on the chronic nature of the insult, depending on the physiology of the patient, and a number of other circumstances, one can find that we have sclerosing osteitis stand alone without rarefying osteitis. In summary, with this particular display, one can see rarefying osteitis stand alone, sclerosing osteitis stand alone, which is an increased density of bone, or a combination of rarefying osteitis and sclerosing osteitis. We can see an example in this radiograph of both the combination of rarefying osteitis at the apex of the 3-6 mesial and distal root and the apex of the 3-7 mesial root. One can also see in examining the causative factor, a very deep restoration insulting the pulp of the 3-6 and caries insulting the pulp of 3-7. You can see in this case again that as you approach the apex, the lamina dura, or that periosteal bone, is discontinued, and you can see, and one can see surrounding the radiolucency of rarefying osteitis, a radiopacity of sclerosing osteitis. We have in this case the combination of both rarefying and sclerosing osteitis. Oftentimes, not always, but oftentimes an indicator of a more chronic situation where this has been a long-standing insult from the pulp to the bone. If the inflammation continues in a chronic nature, two subsequent occurrences may be observed. The first being, and we can see it on this, on the root, the gross caries in the area of 2-7 and the apex of the root, we can see we have rarefying osteitis. This would be considered to be chronic, long-standing, and this may well be filling now, not with exudate, but maybe filling with granulation tissue from with a long-standing attempt to repair the injury. Another case we can see on a standard maxillary occlusal radiograph that we have a radiolucency on the patient's left side, and this radiolucency is well corticated. This would be considered to be a radicular cyst. Although I should point out that from a radiographic point of view, in many cases it is very difficult to differentiate between a radicular cyst and a granuloma until the pathology has been examined microscopically. The hydraulic nature and the cortication in this particular case would be indicative of a radicular cyst. The periapicals of this area, taken after the standard occlusal where this was observed, can show the causative factor of this long-standing chronic inflammatory response. One can see a small amalgam restoration in the tooth. Does not seem to be an offensive causative factor. However, if you look at the tooth carefully, you can see what is referred to as an invagination. The little radiopaque dip underneath the amalgam likely contains pulp tissue, or did contain pulp tissue at one time. The pulp was exposed in doing this very small restoration. We had a chronic, long-standing inflammation occur, rarefying osteitis at one time. This became chronic and has now formed a radicular cyst, which is one of the more common dental cysts to be observed. A number of problems can arise relative to differential diagnosis of the radiolucency or the radiopacity of rarefying osteitis and sclerosing osteitis. Sclerosing osteitis, itis being the indication of inflammatory, sclerosing being an increased mineralization of the bone, is seen with an inflammatory response. In this radiograph, we can see that we have an indication of a causative factor and indeed a considerable amount of sclerosing osteitis. One can observe some rarefaction at the apex and increase in the ligament space. We can see the discontinuation of the lamina dura. This is sclerosis of bone from an inflammatory response. The differential diagnosis of this is an osteosclerosis, an increased density of bone. The absence of the itis would indicate that it is non-inflammatory. Indeed, this is normal bone and of a non-inflammatory nature, and one must be careful that one does not see this sclerosis of the bone and misinterpret it as being an inflammatory response and proceed to treat the tooth accordingly. This is also referred to as a osteosclerosis, a dense bone island, or DBI, or enostosis. Another example of a osteosclerosis as versus sclerosing osteitis. This is diffuse. Although it is not easily seen on the radiograph, the lamina dura is likely present and there are trabeculations within. Another misinterpretation that can occur is in the mandibular second bicuspid region, usually the second bicuspid, and the differential diagnosis of rarefying osteitis and a normal anatomical feature, the mental foramen. Here we see a case of caries on a tooth. One can see at the apex the discontinuation of the lamina dura, the rarefaction of the bone, and rarefying osteitis. This tooth would test non-vital. On another radiograph, although we can see a restoration, it's not impinging on the pulp horn, but the pulp horn may be small enough that it has, and we can see a radiolucency at the apex. Careful examination of this radiolucency under proper lighting with properly exposed radiographs indicates that although we do have a radiolucency at the apex, lamina dura can be observed around the apex of the tooth. Another way of confirming the differential diagnosis would be to pulp test the tooth. Although it does not represent good radiation hygiene, as a last resort, one could obtain another radiograph, and if it is rarefying osteitis, it would remain attached to the apex of the tooth no matter what the beam direction. If it is the mental foramen, it is not proximal or it is not attached to the apex of the tooth, and with changes in beam direction, the radiolucency would move away from the apex. Again, I would repeat, it is not considered to be good radiation hygiene to verify the interpretation from this point of view, but oftentimes other radiographs can be found within the patient's chart, and these radiographs may be taken at a different angle and may illustrate this radiolucency moving away from the apex of the tooth. Another differential diagnosis that must be made is around periapical cemental dysplasia. In viewing these radiographs from the patient orientation point of view, here we see two examples of periapical cemental dysplasia. We can see in the area of the 4-1 that there is a radiolucency. A careful examination of the lucency would show that we have some opaque structures within. These opaque structures may be cemental or may be of osseous, and therefore the term periapical cemental dysplasia. The radiograph, the other radiograph that we can see another display of this cemental dysplasia. It is always wise, regardless of the radiographic interpretation, to do the proper pulp testing of a tooth before proceeding with the assumption that you are dealing with a non-vital tooth. Keep in mind at all times that bone can have various patterns that may mimic rarefying osteitis. You see here an example of normal healing bone. This tooth has been treated, an apiectomy has been done, and one can see a radiolucency that may be suggestive of a granuloma, or since it doesn't have a cortication, an infected cyst, and one may proceed to treat further. There are cases where surgical procedures have been done, a so-called surgical scar has been left, and indeed the radiograph remains this way. Follow-up radiographs show no change. There are no clinical signs of infection, and this is normal healed bone. In this case, we can see a sequencing of the healing of this over the course of a number of months, and you can see that the radiolucency fills in considerably with bone. However, if one took a radiograph of the second sequence, one may misinterpret that as being a reinfection of this area. Follow-up would be in order, and if follow-up were carried through, one would find that the third radiograph shows that the bone has almost completely healed. The radiolucency that is still present is normal bone and should not be misconstrued as an inflammatory response. The response of inflammation in the area of the maxillary, second bicuspid through to molars, generally speaking, can display somewhat differently on a radiograph. A brief review of the anatomy of the maxillary sinus and the floor of the sinus would indicate that we have periosteal bone, similar to the covering of other bones and similar to the lamina dura around the tooth, and a mucosal covering to that bone. The mucosa is the covering of the maxillary sinus, which, when it becomes inflamed, mucus is created, and one of the best displays of this is a sinusitis relative to the common cold or infection of the sinus. In the case of apical insult from the same causative factors as we've discussed, a number of displays can be seen in the maxillary sinus. First, the mucosa of the sinus can form a mucositis and become inflamed and be seen as a radiopaque shadow in the maxillary sinus. On occasion, the periosteum can be lifted or raised, causing a periostitis, or often referred to as a halo shadow. One can also have the combination of both, causing a mucoperiostitis, where the halo shadow forms, and there is also a mucosal insult where we see a thickening of the mucosa. The reason for this is that there is no bone to be insulted per se by the apical infection. It is very close to the floor of the sinus, and the periosteum of the floor of sinus is the reactive area. Here we see an example of a periostitis, halo shadow over a root canal treated tooth. Here we see another example of a deep restoration with a halo shadow over the second bicuspid. Although not as clearly displayed, one can see that the second bicuspid has a fracture, has deep caries, and indeed is non-vital. We can see a very small area of halo shadow or periostitis, and above that we can see the mucosal response of a mucositis. Another area, a badly broken down tooth with the apex quite proximal to the maxillary sinus, and one can see an opacity of the insult of the mucosa in that region. Remembering always that besides the insult that we discussed relative to caries or restorative insult, periodontal insult can also present a rarefying osteitis. In this case, we see a bicuspid tooth, which indeed is displaying a mucositis on the floor of the maxillary sinus. The cause is a significant bone loss of periodontal disease, both in the bicuspid, and one can also observe it in the molar tooth. We've discussed the reaction of the periosteum of the lamina dura relative to inflammatory insult, remembering that this reaction can occur on the periosteum of any part of the cortex of the bone other than articular surfaces, which are covered in cartilage. One can find that inflammatory insult causes a peeling of the periosteum, because the periosteum, as we discussed at the onset, is held by Sharpie's fibers and can be peeled away from the underlying cortical bone. Inflammatory insult can cause this periosteum to peel away, giving what is referred to as a periostitis or periosteal reaction. This reaction can be long-term and is sometimes referred to as an onion skin appearance, a number of periosteal reactions occurring from a long-standing chronic infection. Here we see a periapical of an area that a tooth has been removed, a chronic infection has set up, and some bone sequestra can be seen in the radiolucent area. An occlusal film taken of this area, one can easily see the periosteal reaction that is occurring on the buccal plate of bone. This buccal plate is often the first indicator of the periosteal reaction. Another case where we have a sequestrum of bone, a tooth has been removed, some bone has been without proper blood supply, and we can see that we have a sclerosing osteitis setting up around this area. The possibility with this sequestration of bone is that we have an osteomyelitis, and one would expect that the possibility of a periosteal reaction may be observed, as we saw on the last film, on the buccal plate of bone. This slide shows a full-blown osteomyelitis with a very large sequestrum and involucrum. This patient is verging on a pathological fracture. One must be cognizant, and this is not the place for this discussion, but one must be aware that besides inflammatory responses, we can also have malignant disease of bone which mimics inflammatory responses, and one must always be cognizant of the fact that a proper interpretation is done and a follow-up assessment of the patient's history and a complete assessment relative to diagnosis is carried out. We have seen the inflammatory response to the pulp of the tooth, although similar in many ways to the inflammatory response throughout the body, has some unique features relative to the tooth. These features occur because the pulp is confined to a very, very small apical foramen for entrance and exit of blood vessels, lymphatics, and nerves. The sequencing of events that occurs with the insult to the pulp is that we have a thickening of the lamina dura, oftentimes an increase in the membrane space, followed by a discontinuing or breakdown of the lamina dura, a rarefaction of the bone causing a radiolucency and rarefying osteitis, and either separately, stand alone, or hand in hand with the rarefying osteitis, one can see a sclerosing osteitis or increased density of the bone. Chronic long-standing inflammatory responses may generate a granuloma or a radicular cyst. A radicular cyst is usually more hydraulic and better corticated. One cannot differentiate from a radiographic appearance the difference between a granuloma and a cyst until the histology has been examined. Differential diagnosis, a number of differential diagnoses occur that one has to be cognizant of in reviewing and interpreting the radiographs. One is that sclerosing osteitis may differentiate from normal bone. There are dense bone islands or areas of sclerosis that occur normally within the bone and should not be misconstrued as an inflammatory response. There is a fibroosseous occurrence, periapical cemental dysplasia, which mimics rarefying osteitis. A careful clinical examination and pulp testing of the tooth must be done to differentiate periapical cemental dysplasia from an inflammatory apical response. The periosteum of the cortex of the mandible can often display a response to inflammation. This response displays itself as a periostitis. At times, this periostitis can be multi-layered, indicating a so-called onion skin appearance. These appearances often occur with infection of bone and osteomyelitis. One should always be cognizant of the fact that there are a number of diseases which may mimic inflammatory response. One of the more serious is that malignancy in bone may indeed mimic inflammatory response, and of course the consequences of this is far different, and the treatment is far different than the treatment of a devitalized, non-vital infected tooth.
Inflammatory effects on radiographic interpretation has been presented by Dr. Ross Barlow, Assistant Professor, Department of Oral Maxillary Facial Radiology, Faculty of Dentistry, University of Toronto.